folks who aren't able to attend or folks that want to refer back have access to that. So if any of you would like to have access, feel free to let me know. I'm going to share my email in the chat. I'll go ahead and get started. So my name is Soliana Goldrich. I am the Maine EMS Community Paramedicine Coordinator. So I oversee sort of CP related initiatives at the state level. I also have with me Jason Oko, who is the Maine EMS Data and Preparedness Coordinator. Does many things data related, MEFIRS related, has been with the state office for many years. So I'm sure lots of you folks have had wonderful interactions with him. So today is really meant to discuss the changes in CP reporting. So most of you have probably noticed this thing called the community health module pop up now, which is what you will now be reporting in. So today we'll just kind of do a walkthrough of what that looks like, and then at the end have a time for Q&A, any questions you guys have. I'm guessing questions will probably come up as we walk through, so feel free to add those in the chat as you think of them, and I'll make sure that we can get to them at the end. But I'll say before we get started, does anyone have any burning questions? Okay, I will take the silence as a no. I'm going to ask Jason if he can share his screen with us to show the community health module.
Can you see my screen?
Yes.
Okay. So hello, everyone. Thank you for coming today. Did you press record, Soliana?
I
Okay,
did.
good. Okay. So we're just going to walk through, beginning to end of the community health module. We've developed a new run form. It is the Maine EMS CP run form 3.5. 3.5 is just saying that it's on the NEMSIS version 3.5 data set. The reason that we had to go through this is, a few reasons. Number one, we've eliminated anything community health, mobile integrated health, community paramedicine related from the 911 and interfacility run form that we use at baseline, that every agency uses. This run form allows only agencies that have received community paramedicine designation through the application process to use this form, to use this data set, so that these records are separate from the 911 records. Now, when I say separate, it's just a separate listing of the records, right? So it has its own incident list, it has its own run form, it has its own views that we can go through, but we can report on them the same way, right? So a lot easier for us to glean information out of the system for how CP is performing. Repeat patients do, however, follow through from both sides of the form. So if you're a 911 agency that has seen a patient and then they become a community paramedicine patient for your agency, their information will be available to you as a repeat patient in this run form, right? And so one of the other really nice things about this run form is that we can take this run form and remove all of the non-essential items from the 911 run form for community paramedicine. So we don't have to say, we don't have to talk about loaded mileage. We don't have to talk about lights and sirens. Like, we do a little bit, but we don't have to, and some other things. And so we're at our own leisure, so to say, to make this what we want, right? We can make it as simple as we need to, and then we can continue to build upon it to make it more useful as the program grows. So I'll tell this to everyone, there's a few ways you can interact with us during this, right? You could raise your hand and we'll call on you. You could throw questions in the chat, and then there's a Q&A button I see that's active. So you could throw Q&As questions in there, and we'll do our best to answer them. We'll probably answer them live. So we'll just go, and I can just go on and talk about this all day. So if you have questions, please raise your hand and ask questions. If nobody raises hands and asks questions, we've got a list of names. We'll just call on people by name. So
Jason is joking. And I will say, just to sort of like piggyback off of what Jason said, the goal of this is really to, not the webinar, but the form, is to make a lot more sense for CP related calls. So it should look shorter than you're typically used to, but it should interact similarly to what you're used to interacting with. And the order of things looks a little bit different. So it's more relevant to what you are doing on a CP visit as opposed to a 911 response.
okay, so we'll get going here. So the first, I've tried to keep this flow the same, right? So if anybody here has written a 911 run form, we have a flow that we use. If anybody's done the MEFIRS training on MEMSED, there's the dispatch, response, arrival, assessment, treatment, transport flow, right? It's the DRAT narrative format that I like to follow. So this run form flows the same way: dispatch, response. We have moved signatures up, right? And there's a specific reason for that, and we'll talk about that in a bit. Arrival, assessment, treatment. And then we call this transport and disposition. There's typically not transport of a community paramedicine call, but if something was to happen, we can use this transport and disposition tab to transition. Like, this run form won't transition into a 911 run form, but we can indicate here that this patient needed to be transitioned to a 911 run form. So we'll go through that too. And then the narrative tab, and then thank you, Waterville Fire Department, for walking me through this. But there is also fire agencies that are participating in community paramedicine. So when a fire agency does go on any type of incident, be it an EMS call or a CP call, there is an accompanying fire report that goes with it. So we've added the ability to create a fire incident associated to this incident right here as well. So without further ado, on the dispatch tab, the crew and unit information all on one. You can add your crew members. This is just a list of people in the office and other fun folks. So you can add your crew members. There's no requirement to however many crew members that you have here. So you can add one if there's just one person going out. I would encourage you to add all the crew members that are responding to your incident though, right? If I was logged in to this and I was actually logged in as Dr. House, this would have defaulted for me. So call sign populates from the unit number populates from the call sign, and that's required here. And then the unit transport and equipment capability is defaulted to whatever this vehicle's capabilities are. Scene of visit, this is just the address of the visit here, right? This isn't the patient's address. This is where your visit is, right? So we've had several questions of can this populate off of the patient's address? It could be different, right? So you could be going to an assisted living facility or a nursing home. They also could have moved. They could be somewhere else, right? Staying somewhere for a brief period of time while their house is remodeled. Who knows, right? For whatever reason, the scene address is important here. So we'll just collect that information here. There is the incident address favorite postal code. So if it's in, Springvale or York, Maine, it'll populate all that stuff for you right here, or Bangor, right? And then all you have to do is put in the street address, right? So, okay. On the response tab, there's just a couple of numbers here, right? So this community paramedicine visit number, this is a number that can be specific to your agency. This isn't for us. This is for you folks at your agency. And this community paramedicine visit number is available under the auto number feature in the configuration tab of MEFIRS, so that you can set it up to reference it however you'd like, right? So and that will auto populate there as well. We have moved the signatures tab up here, right? We haven't added that specific language yet as why we wanted the signature tab here, but this is a placeholder for that. But the reason that we moved the signature tab here is because it's early on in the flow of the run form. And this gives us the ability to obtain patient consent when we arrive on scene. It's an important thing to do. So during a community paramedicine visit, it's a much different environment than that of a 911 call, where we're trying to determine the need for the patient to get to the hospital really quick. Here should be a little bit more relaxed environment. One of the first things we should do is obtain consent. I think Soliana has more on that.
Yes, yeah, I know. This is definitely probably one of the bigger changes, I would say. Um, you guys are probably used to seeing the signature, obviously, at the end of the form. It's really important in non-emergent care to receive consent at the beginning. If a patient is not able or willing to consent to treatment, then you would not follow through with treatment. This is also really important for liability. Once you get into kind of the non-emergent space, it opens up potential avenues for increased liability. So having the patient consent and signature documented helps avoid some of that risk for the agencies. And there's a bunch of different options for patient signatures. You can go over HIPAA, releases of information, all those types of things that you might want a signature for here. I know not every agency utilizes things like iPads, but this can be really helpful for sort of the CP world and receiving consent like physically there. That's all I'll say for right now.
Right. Cool. Um, so one other thing here, you notice we have the patient sign it, it's still red. There's one more signature that's required, and that is the EMS clinician signature. And then that'll clear the validation on that box right there. That's just saying that you've provided the care for that event. So on the arrival tab, you're going to see a lot of things here that are very similar to the 911 and the interfacility run form. So run form 5.0. Incident location type, is it a private residence? Number of patients at scene. Let me plug in some times to make sure I've got everything coming in, right? So, okay. Number of patients at scene, not a required field, but each patient requires their own individual patient care report for each visit. So, patient name, repeat patient is available here. You can use that. We do have a test patient in here. That should pop up. Maybe it's been too long. We'll just go through this, right? So uh, if we're going to load in a patient, oh, that's the last name. Going through these, race is an important question. This is sort of new to our run form. It's always been on our run form. However, in the past, it's been selected to not recorded, and that cleared the visibility, the validation rule there. We would much prefer that we have a conversation with our patients about this and ask them if they don't mind us asking them a question about their race and what race they identify as, and then that will there we go. There's a repeat patient, and then that will give us the ability to collect that data, so that we can, because it's data that we honestly quite honestly have never had before. And it's important to us to understanding our system and eliminating disparities in the care that our patients receive. Come on, download. All right, it doesn't want to do repeat patients. Oh, there it goes. It loaded it in, right? So, the veteran status question, we are still asking that here as well. This is also relative to this is part of a repeat patient record too. Patient address, their home address comes in. If it's not populated, already loaded an address here. And patient employment, emergency contact. We haven't put any requirements on these fields yet, but we may potentially put some at a later date. And the emergency contact is the other kin field. On the medical insurance tab, the primary method of payment. A lot of people have been asking about this because this is also a required field on the 911 run form for transported patients. And this isn't what is your, who's your insurance company, who's the, who holds the insurance, what's the codes for your insurance, what's your insurance, not that, just what type of payment is it, right? So is it Medicaid or Maine Care, Medicare? Do you have private insurance, so on and so forth? And quite literally, that's the only question that we're asking there. Trying to understand a better band of our payer mix, right? And I'll give you an example because we don't have a lot of this data right now. But if we do have a better understanding of our payer mix, we can go back to the payers and we can say, hello, Maine Care, you take care of X percentage of our patients. And that may give us the ability to say, this is why we need better reimbursement rates, right? This is, this is essential to the EMS community, right? So I'm going to pause right there. We're about halfway through. Does anybody have any questions that they'd like to ask? Again, you can raise your hand. You can throw your questions in the chat. You can unmute and ask. You can throw it in the Q&A. Whatever you'd like.
Hey, Jason, it's Rick.
Hey, Rick.
I've had more of an operational issue of people filling these out when they're trying to do emergency reports. And just finding them a little difficult to delete or make disappear.
Okay, so you won't be able to transition one of these from a CP from the community health module to a 911 run. So the only option you'll have is under the menu here. And it's one by one is to hit the delete button and it'll delete that incident.
Yeah, initially, like early on, I haven't checked in a couple weeks, but when it first started happening, I didn't have that button. The best I could do was status mark for deletion, and
okay,
that was all I could do.
We could that actually works too, right? Typically in reports that Darren and I run, we exclude reports that are marked for deletion. So so that'll work too. I'll check the permission groups and I'll make sure that EMS agency admin and fire EMS agency admin have the ability to delete CP records. All right.
Thank you.
Be very careful with that though. If you accidentally delete a record, Image Trend can't recover it. So I wouldn't be very careful of that. Okay.
Always double check. Yeah.
Yeah. And it asks you, are you sure? So. All right. Any other questions from other folks? That was a great question, Rick. Thank you for asking it. Breaking the ice. All right. So we'll go into the assessments panel, right? This is a new change. So we've relabeled some of the questions that we had on our last run form. These are the same questions, however, just with a little bit of a qualifier at the end of them. Has the patient been to the emergency department in the last 30 days? Yes or no? Do you want to talk about why we did that, Soliana?
Yeah, so this, the 30-day mark is really important within the healthcare community. This is helpful for us to assess how well CP is doing at avoiding hospital readmission. It's also helpful for how much potential money is being saved by not having a patient, readmit to the hospital. So this is really valuable information and is pretty quick with patient report. Obviously, not every patient accurately reports, but it is better to have some information than no information for us for the future, working towards reimbursement and assessing for how well we're doing statewide. I see Steve raise his hand.
Good, Stephen.
I did. I also, just to add on, we've been using this for quite a while for grant reporting. So this is one of the huge questions they ask for grants, and we have to report this off to them to prove that we're using our grant money and hopefully it's working.
Yeah, that's, I mean, the data, you know, I know sometimes like additional points can feel like burdensome, but it is really helpful to have data from your end to go back to municipalities, grants, whoever, contractors, and say, this is what we're doing and this is what we're providing service-wise. So please pay us for it so that we can continue doing that good work.
Yeah. This also, part of the study that we did when we with University of Southern Maine and with Maine Care, it was difficult to ascertain, like, so what's the point that we go back to? And 30 days was the 30 days was the best timestamp that we could find for that, right? So so this is sort of I like to refer to this as dynamic or choose your own adventure-ish, right? Because if you say yes, it's going to ask you some follow-up questions, right? So emergency department visit date and to estimate it if necessary, right? Because some patients may not, I know this is going to surprise a lot of you, may not be the best historians, right? But you can estimate it if possible, right? And then also, what was the primary reason for the emergency department visit? And we have a list here. It is kind of it's kind of a tight list, right? So, but there is an option for other, right? So, and these are very, very broad topics here. Okay, so choose from the list. If not one of those, select other, and go for it. And then we have the disposition, right? So, I'll just add a few days ago, and we'll say it was for a fall. And then what was the disposition of the emergency department to visit? Now, meaning, did this patient, get admitted to the hospital? Were they discharged to home, discharged to a skilled nursing facility, rehab, or did they leave against medical advice? Did they elope from the emergency room? So, and then make those selections there, right? Has the patient had a hospital admission in the last 30 days? Yes or no? Same concept. Admission date, estimated necessary. What was the reason? And what was the disposition, right? So I'm just going to mark no on that one. And has the patient seen any other healthcare provider other than the CP in the last 30 days? If you say yes, the patient practitioner's field will flag red. And we're just looking for what type of practitioner was it, and we'll just say urologist, right? And then as much information as you can plug in here. None of this information is required. Hopefully you'll have as much information as that. And I know exactly what Heather's going to ask. She has her hand up and she's going to say, can we link these together to that clinician? Go ahead, Heather. I'm going to ask you to unmute.
You're muted.
Actually, I wasn't going to ask that, but it would be great if we could.
Yep.
A link to the
Yep.
NPIs that would help with billing, but
Yep.
we'll get there eventually.
We'll
probably.
get there. We will.
But for today, my question is it possible for patients that are receiving follow-up care to also have a flag in the system when they develop or are released with an infection or a complication from inpatient treatment?
So
because there's both federal and the state mimics the federal because we're required to, reimbursement differences for the inpatient's treatment and there's also quality measures when the patient has post-op or post-surgery or inpatient or post-discharge hospital acquired infections or complications from the treatment they received. And so we would want to prevent those from disappearing in the community paramedicine treatment and not ever being accounted for. And so if they could be accounted for here, that would help us to track that.
So are you thinking, so it would be, so I love the thought process about asking about infections, right? And I think Steve Smith will attest to that for me. But are you saying like we should add under like was the patient uh did the patient have a hospital admission in the last 30 days? Yes. If yes, right, was one
Right.
of these questions being, was there a hospital acquired infection that we are aware of? Yes or no?
Like yes, like at this episode of Community Paramedicine Services. So as part of this assessment, does the patient present with an infection that appears to be hospital acquired or hospital related? Sometimes that's going to be difficult to say, right? And sometimes
Hospitals are going to love us.
they're going to love us, but it is part of building this relationship, right, that has been beneficial for the patient, but it also holds everyone accountable for the pieces and parts of reimbursement and the services. And um you know, and it covers you in the sense that it
I
covers
love
the
it.
community paramedicine
Yeah,
provider in the sense that you're tracking it. Anyway, and it just helps us resolve any of those issues. So
yeah. So I love that, and I think I think we could build a pathway to make that happen.
mhm,
Um, I kind of want to think it through. So
sure.
maybe we can make it more articulate than just all the time, right? So if they had a hospital admission and it involved maybe if it involves something specific, we ask that question, or and maybe we put something on our assessment tab, right? Because we are going to do like a physical exam of the patient
Mhm.
here too as well. So that might be something to add at that point. And if you don't mind, can we schedule something sort of offline though to talk about that a little bit further? I know
100%.
every time you ask me something, I'm like, let's talk about that offline, but let's really do this, right? Because I think that's a work. I love the thought process there, and
Mhm.
sepsis is always something that um is horrible. So
Yeah, and you could even have the kind of language that is it does it up here. The
right,
patient has to, so that you know what I mean. If the
yeah,
community if there's a question about the diagnostic piece and the level of
yeah,
certification of the, it could. But yeah, let's keep a list of these running things to make sure that as we roll out the main care payer model in the future, we have as much alignment as early as possible to support reimbursement.
you're on top of that, right, Soliana?
Yes, I made a
Okay,
note and I
Of course
will
she is.
touch base
fan,
back with Heather. Um,
fantastic.
I was going to make another comment about the asking about patients. That's really helpful for sort of seeing where CP is interacting with the rest of the healthcare system. This can also be an opportunity if like, hey, you saw like John Doe at blah, 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 and maybe it's helpful for the patient to have a release of information on file so that you can connect back with them. That gives the opportunity to have that conversation. If this is a patient you're seeing again, and last time they said, yeah, I saw my cardiologist and I'm supposed to go next week, and all of a sudden they're like, hey, I haven't seen any provider. That's also an opportunity to like sort of check back in about their care and reconnect them back.
Absolutely, that's a great point. Um, okay, so any other questions? Any other feedback? All right. So the reason for the visit tab, right? So this reason for the visit, this is relabeled, but this is, um, if you're familiar with the 911 or inter-facility run form, this is the chief complaint grid, right? So why are we visiting this patient today? And this is a free text field. What is the reason for the visit, right? The reason that we're asking for this is just to say, you know, we're going for follow-up. We're going for these. We'll have a question later on, like what is ordered for this patient, um, for whatever those are, or if we're following up with the patient because they're newly diagnosed diabetic and we're going to do diabetic education, or whatever. But the reason here can just come right in, right? So, one in, hit OK, right? Patient history. A lot of the same things that are available in the current run form are also available here. Barriers to patient care. I think this is a huge one. This was on our run form previously, and we haven't, and it was defaulted to none noted, so it just sat there just like that, right? And nobody ever touched it, right? But now that we removed that default, we're getting we're learning how many people can't hear, and I'm one of them, right? So, but these things are important, right? If the patient is sight impaired, it's difficult. It may be difficult for us to do certain things with them, right? If they're hearing impaired, it would be very difficult for us to do certain things with them, right? If they're uncooperative, right? And that's a barrier for our EMS clinicians when they're going out to do this. So, and it's important that we document these things. So number one, so we can tell our story later on, but we can understand how we need to train our clinicians to navigate those barriers, right? Alcohol drug use indicators. We're going to have to ask that question, and the non-reported will clear the validation. However, it's a super easy question to ask. I ask it of all my patients. Any drugs or alcohol not prescribed to you that you've used in the past 24 hours, and they'll tell you, right? Medical surgical history. Obviously, this comes over with repeat patient information also, but it is important that we verify it at every step, right? Current medications, medication allergies, these are required fields. If they're not taking any current medications, then you can clear the field with the non-reported grid, and it'll clear that. And medication allergies has no known drug allergy as well for the allergy field as well. So, or you could select from the grid and you could say they're taking Eliquis, right? And then you can open it up and you can do more of the dosage unit frequency, and the route, if you'd like to. And there's a whole bunch of information available for every single medication in here. And you can, nothing is required more than the name, but the more you enter, the better luck you'll have following up on things. Just going to clear a few of these things out here. Reported. Right. So vital signs. Do you remember what we listed as required? We have a blood pressure required, and I think we're going to require heart rate, respiratory rate, and a temperature as well. Am I correct on that?
Yeah, just kind of sort of the basics. I mean, typically folks are doing all of this anyways, but
Yep.
That way you just have a baseline for assessing, especially if you are going to go to a patient more than one time. You can tell like, hey, their blood pressure is drastically different than last time.
Yes, and glad you mentioned that, because you could see that in the timeline, and you could look at the patient encounter, and over the last 90 days, you could look at something like their blood glucose if this patient was diabetic, and it would show the trend over the last 90 days of where their blood glucose was, which is an amazing tool to have at your fingertips. Blood glucose, heart rate, weight is in here, right? If you're dealing with a CHF patient, so on and so forth. So thank you for mentioning that. So and then we have the physical exam, right? There's an exam grid that you can click the plus add here. And yeah, that's the way we're gonna go with this, right? So we can add the exam, and we can talk about what's the date time of the assessment, anything that we need to add from their mental status exam. It's required that we have an exam, and obviously I would work with your medical directors and to determine how much detail they would like in the exam. I much prefer this over just typing my exam in the narrative, because I can hit every single body part here, and I can identify, it's the left eye, right? And it was, 6 millimeters, right? And I can add that their right eye was 2 millimeters, and that's a unusual finding, right? But much easier to use this, I think, than adding it in the narrative and typing it out freehand. And then there's less opportunity for mismatching something, and you can unduplicate your efforts because this will show up on the print report. So, mental status alert. Okay. Under the treatment section, we're going to have what has been ordered for this patient. Should be a familiar element to everybody. We've had this on our CP section of the 911 run form for a long time now. And this is a multi-select list, and you can just select from this list what has been ordered for the patient. If you start to come across things that I think everything from the scope of practice is here, Soliana. But we should just double check that to make sure. I think everything is here. This is a very long list now.
Yeah, some of it is not what you're currently able to do, but this is for
Oh, okay.
future use. Like
Okay.
Foley
We
care.
we can deactivate that if you'd like for now.
Yep.
So we'll do that. And then, if something's ordered like a 12 lead, we're going to say, all right, yeah, go ahead and document that 12 lead right here, right? And so then you can click add, and then you could say that this was a 12 lead, and you don't need the lead because it's a 12 lead, right? And then you can go ahead and diagnose the rhythm, and you can upload your EKG, right? And you can scan and attach it right here, and then the attachment will attach to the run form, or you can import it from your cardiac device, your cardiac monitor, and it'll populate this field as well. So community health, right? So this is our questions that we have about who ordered this visit to this patient, right? What was their practice, and is there a referral from? Like who referred them? Was it, their physician, or was it the, insurer, so on and so forth, right? Does anybody have any questions yet? Or not yet? We've already had questions. Anybody have any more questions? Okay, we'll keep going. So the transport and disposition tab, right? This is defaulted. The type of service requested, we've defaulted it to the a mobile integrated healthcare encounter. And I'm sure you love that, Soliana. And we've defaulted the unit disposition to patient contact made, right? These are the dispositions from NEMSIS 3.5 that we are using in here as well. However, they are defaulted to that, right? And I think what I'm going to do is I'm going to build a preset value for something that says, okay, we came and we saw this patient, but we needed to call 911 for them, or we needed to transport them 911. That will change these dispositions for you, right? Because essentially what's going to happen is this last one, this transport disposition, and possibly the crew disposition may change, right? So if you always go to a CP visit and you arrive at a patient and you make patient contact, hopefully you're going to provide an evaluation and care. The evaluation and the assessment, that is the care, right? Performing a 12 lead or collecting vital signs, that is the care, right? The crew disposition is, did this crew initiate and continue the primary care, or did you transfer care, right? So I'll show some values over here. And if you had to call an ambulance for this patient when you're there on a CP visit, initiate and continue primary care, if you're the ambulance, is fine, right? You could say that and leave it there. But if you have to call another agency or another ambulance to come and transport this patient, initiate primary care and transfer to another EMS crew would be the appropriate choice in that instance, right? And then the transport disposition should actually change from no transport to transported by another EMS unit, right? Because then that would be the patient's going, right? And hopefully they're not going in your fly car or your community paramedicine or your personal vehicle, right? But that would be, after you write your narrative, that would be the end of your community paramedicine visit report for that patient. And that crew that's transporting the patient would write a complete separate patient care report in the 911 system. So questions from anybody at all? And we'll go one by one if nobody asks any questions.
Can you show how to get the trend value for the patient's vital signs again? I think you said it was under timeline, but I didn't quite
Yeah.
catch it.
Absolutely. So under timeline, it'll follow up and here will be the incident timeline, right? These are all the times that we've documented here. And this is a great feature because you know, these little arrows, right? So this will take you to that value, right? So right back to the patient signature, right? But there's the patient encounter, right? And I don't know when the last time I wrote a report for test patient is, but we'll take a look. And I typically I fly through these things. I don't really document too many things, but we'll check the blood pressure and see if it'll show anything it's thinking. But it's under this patient encounter, and there's a graph or data because it'll just do a list of data too. But I don't know. Oh, there we go. So there's today's, right? That blood pressure that I just documented a minute ago. But if we, you know, nothing for heart rate, weight. Yep. So there's weight, right? And it'll show it in a graph. We're not editing this stuff for this patient as we go along, right? He's just, you know, an even 113.4 kilograms the whole way through. So, but this is a fantastic tool. The other thing that'll show up in here is medical devices. Old EKGs will show up in here, right? So if you do an EKG for a patient, they will show up in here, as long as they were attached in the treatment in the EKG section, and you attached it. That old EKG will show up in here, like you'll be able to see it. So it's actually really cool. So great question, Robbie. Thank you for asking that. Andy, do you have any questions? Oh, Stephen has a question.
I was trying to let other people go
Two
first. Report writer, how's that gonna work out?
Same way.
Same way, I'm just have to build it based off from the disposition and whatnot.
Nope, I would build it off of the type of service requested being
Yep.
equal to mobile integrated healthcare encounter.
Okay.
Because fun fact, this is not available in the 911 run form.
Ooh, right. So it's coming off. Okay.
Hey, Jason, this is Everett from Waterville Fire.
How we doing?
Good. Hey, for the patient encounters that you had popped up there, will we get any data at all, trending data on like procedures like wound care or anything like that?
Procedures aren't listed. Yeah, procedures aren't listed here. So no procedure. You won't see like what procedures have been performed for that patient in here, other than medical device and blood glucose readings. So
And my only other question, for community paramedicine, will there be, or is there any discussion regarding a pathway for options referrals?
It's a great question. There has been discussion. I think a lot of sort of the SUD team's initiatives are currently sort of in like the piloting phases. And so I think the end goal is that they will live or be housed within sort of the CP realm. But for right now, that is based off of sort of a 911 system. It doesn't mean you couldn't do a referral to options though, but you would have to have a release.
Okay,
Does
so
that
if we
make sense?
have, yeah, if we still generated a consent form.
Yep.
How would that, would we just contact options ourselves direct, or would it still be the referral process still through the PCR somehow, or how would that work?
we can talk
Let me-
about adding an options referral to this, because the options referral is through a signature grid and a signature type. Let me talk I'll let Soliana talk to the substance use team and see if that's something that they're interested in.
Yeah, I'll have to see because that might be because it's agency specific right now. Like not all agencies are doing that. So,
Not anymore.
oh, sorry, misspoke.
Yeah, I would appreciate that, because, you know, arguably, you know, through CP, you know, we could potentially get more option referrals, you know, in a non-emergency type encounter, versus an emergent encounter where there's so many other variables going on. So I would personally love to be able to see, an options pathway built into this.
Yep. Yeah, I'll touch base with the SUD team and see what we can do, and if we can put that in here. But I would say in the meantime, you could just do sort of releases of information, and then do referrals separately. But I'll touch base with them very quickly.
All right, I appreciate that. Thank you.
It's a great question though, Everett. Thank you for asking that. Dakota, do you have any questions over from Medcare Way?
That I can think of right at the moment. I know I'll have some probably after we get done this meeting. So
No problem.
Jason, I thought you were joking about that. I did have
No,
someone
dear God, no.
message me a question about signatures and if they do reporting afterwards. I would say I think in general it's easiest if you do concurrent documentation, like you're documenting while you're with the patient. If not, I would receive just consent prior to treating the patient, and however that looks like for you, if you want to do physical signatures, like on paper, whatever your sort of typical pathway is, you can do that. Oh, sorry. Andy said she couldn't unmute herself.
She wanted to know what the meaning of life was. I did send her a private message though. Steven, you have your hand back up?
I forgot my question now. If it comes back, I'll.
Thank you, Steve. So what I was really trying to do was work my way down to Grammy in the participant list. Grammy, do you have any questions? I hope she does. But anyway, we'll come back to that. If anybody does have any questions, I know at the beginning of the meeting that Soliana and I both put our emails in the chat. Feel free to reach out to either one of us, right? And we will be happy to answer any questions that you have at any point in time. And we are going to take this recording and share it on YouTube. I saw Waterville unmute. Do you have a question, or was that accidental unmute?
Yes, no, I do have a question, one more, I think, for you guys. We had been discussing about, you know, if it was repeat patients that we go to, get referred to, is there any sort of pathway where we could access sort of seamlessly if we had a visit where photographs were taken of like wounds or something like that? Is there any sort of easy way to access those previous photographs or information as a reference? Or would we just have to research the previous CP incident in order to view the photographs and other attachments?
So that's a great question. So in the patient records section, I'm not sure if there's a place for images of injuries or wounds or, you know. Now, Grant, I've done that before, right? In the emergency run form, you take a picture of something and attach it to the incident. And trauma docs love that, right? But we can take a look and see if there's a way to, because you could put a profile picture for a patient, right? And I don't know. I don't know if it would fall under documents if we could. I guess you could add a file type in their document if there was an image, if you had like a JPEG or something like that. You might be able to do that, and I think I might have one handy. I don't know. All files, no pictures. So yeah, you can add a JPEG if you have the image, right? You can add it because I just added the picture of, Medicare's fly car right here for this patient. So
I would have to add, the image would have to be added through the patient record.
Yep.
Opposed to like the actual PCR.
well, I don't know, right? Like I've never tried that, right? To go in and take a picture of something using like the device, like an iPad or a tablet, and then save it and then come into the record later to see if it's available in their document section. I've never done that. So it's something I could test though, because in the patient record, you could, in theory, click on attachments and take a picture of the image and then upload it. And I'm just not sure if it'll go to their patient record or if it'll stay part of that incident. Nobody's asked me that question before and I've never tried it, but it's a really good question and I'm going to test it and then I'm going to let you know.
Okay, thank you.
Anybody else have any questions? Like Gorgie might have one. Okay. Any closing statements from you, Soliana? I'll stop sharing.
Perfect. Well, I will say I appreciate everyone coming today. We will be having the recording go out, but if you specifically want me to send it to you, just let me know. Feel free to shoot me an email. And then again, if you have any questions about either the community health module or community paramedicine in general, or just want to talk about ideas for the future of community paramedicine, please don't hesitate to reach out. I love chatting with you all and getting your feedback, especially from folks actually providing the service in the field. But thank you all for coming today.
Thank you. Have a good day, everyone.
Thank you, folks. Appreciate it.
Thank you.